traumatic injuries, and he's doing research at the University of Buffalo, and he's here to talk about complete concussion management. So take it away, Tom.
Sure, thank you. I'll kind of just give a bit more of a background on myself. I'm a chiropractor. I graduated a few years ago, and then I got into a sports medicine residency, which I've been doing for the past 3 years. And throughout my residency, I got interested in the topic of concussions. It was right around the time of the Sidney Crosby injury, and through that, I kind of linked up with the University of Buffalo. So if anyone's familiar with the research that they're doing there, particularly with exercise in post-concussion syndrome patients, I'm kind of working with them on that. So without further ado, we'll talk about some sport concussion stuff here. So first we'll just talk about kind of the definition from the most recent Zurich consensus. Is everybody familiar with Zurich? No? Okay. And then we'll talk about the pathophysiology, kind of what actually goes on inside the brain from the mechanisms. We'll talk a bit about the acceleration values, both imposed to the head and as well as a potential injury to the neck that can happen at the same time. And then we'll talk about initial management and return to play activities, which I think is definitely crucial for your physicians. And then we'll talk about post-concussion syndrome, and then we'll talk about kind of how our program works as a network for interprofessional collaboration for these injuries. We just met with the performance vision optometrist today, that's kind of his area of expertise. So we're kind of utilizing all these different fields and bringing them in together with people that are interested in managing concussions and also have kind of some expertise and knowledge in different areas, so that kind of get a global picture, everyone working together. So the most recent definition from Zurich, the Zurich consensus happens every 4 years or so, and it's a collaboration of experts from around the world that get together and develop a consensus statement based on what the current literature says. Now, their most recent definition is a complex pathophysiological process affecting the brain induced by traumatic biomechanical forces. The common features, they may be caused by either a direct or indirect force to the head. Now, this is another misconception common in both medical and general population, And the idea is that if you're not hitting the head, you didn't get a concussion. And that's actually false, because a concussion is an acceleration injury. And so if you're even hitting the body and enough acceleration transmits to the head, you can get a concussion, because it's the brain moving inside of the head. Now, the most likely way to get a concussion is obviously from a direct impact, but just because somebody didn't hit their head, if they're exhibiting symptoms of a concussion, they still could have a concussion. Okay? It results in the rapid onset of short-lived neurologic impairment that typically resolves spontaneously. In some cases, may evolve over minutes to hours. Some people have symptoms right away. Some people, as time goes on, over the next 3 to 4 hours, they'll start to experience headaches, dizziness, nauseousness, all these different things. So there can be a delayed reaction, and we'll talk about why that is. Acute clinical symptoms reflect a functional disturbance rather than a structural injury. So on your special imaging, your CT scans, your MRIs, in most of these patients, you're going to have no abnormalities whatsoever, which makes the diagnosis that much more difficult. Just because there are no abnormalities, however, does not mean that there isn't a concussion. I frequently get patients in my practice that will come in and I'll ask them about concussion history, and they'll say, well, I went to the hospital, I had a CT scan, and the doctor said I don't have a concussion. Well, that's actually incorrect, because the CT scan will only show any structural abnormality, and in a concussion, you're not likely to have that. May or may not involve a loss of consciousness. Again, this one is another misconception that's common. Well, did you lose consciousness? No. Well, then you didn't have a concussion. In fact, more than 90% of these injuries do not result in a loss of consciousness. Okay? Concussion and mild traumatic brain injury in 2011. They're often used separately in the research that's out there, but if you look at the neuro research, they use NTBI. If you look at the sports literature, they use concussion. And in 2011, the World Health Organization tried to make those two one. So concussion is mild traumatic brain injury, and so it just depends on what type of literature you're reading, but just know that the two are the same. So what happens with concussion? So we already mentioned that concussion is an acceleration injury. One of the things that was common thought back in the day was that the brain would hit the inside of the skull and then bounce back and hit the other side of the skull, creating a coup contra injury and a bruising of the outer matter the outer gray matter of the brain. If you Google concussion and look at the images, they still show the concussion bruise. However, the more recent knowledge that we're getting is that concussion is actually more of a white matter injury, more of a deeper structure injury from the axons. And what happens is that the brain actually expands and contracts on impact. So you get a stretching of the neurons in the white matter. And so with that stretching, you get I can't talk right now. So you get a deformation of the neuronal membrane, and you get a release of potassium outside. Okay, so remember the concentration gradients: potassium wants to exit, sodium wants in. So with that expansion contraction of the membrane, you get this exchange of ions. When that exchange happens, you get a depolarization of the nerve, and you get a bunch of action potentials that happen. Okay, so you have millions of neurons all at the same time that are basically tricked into thinking that they've received a signal. So you get nerves just firing like this. So it's almost an electrical storm inside the brain. So increase in extracellular calcium, depolarization, and action potentials. Now the action potentials obviously release excitatory amino acids, which then propagate that signal, and so you get this kind of spreading of those action potentials that transmit throughout the brain. And that is the cycle that kind of goes on. Okay, so this first part of the phase here is the excitatory phase of concussion. Okay, so there's two parts to the concussion injury. The first is the excitatory phase, which is what we're talking about now. So this glutamate that's released from these firing nerves opens up what's called N-methyldeaspartate, or NMDA receptors, which open calcium channels and allow calcium influx into the cell. Now this is actually the biggest problem with concussion injuries. Calcium gets inside the neuron and disrupts all sorts of physiologic processes, which lead to a reduction in ATP. So the intracellular, here it is right here. This is the main picture right here. So this is from a study by Giese and Hope. This is the famous concussion picture. So we have here synapse. We have polarization, release of neurotransmitters happening here. We have potassium efflux here. And then we have the calcium influx somewhere in here. So we have opening of NMDA receptors right here, calcium influx. Calcium actually enters inside the mitochondria and disrupts the electron transport chain. So it disrupts the ability to produce ATP. Okay? Now, because we've created this depolarization on a large scale, this sodium-potassium pump here actually has to kick into overdrive in an attempt to reset the ion balance within the neuron. The problem is that pump, even on a normal basis, is about 2/3 of the ATP produced in our brain. So even in just normal resting homeostasis, that ATP pump is going pretty strongly. Now because of this huge imbalance it's created, it actually kicks into overdrive, and we start utilizing a whole bunch of ATP. Okay? So here it is, increased ATP use. Now because the calcium has disrupted the mitochondrial function, we have a decrease in the ATP production. And the net result is an energy crisis. This is the second phase of the concussion. So the initial concussion injury, that insult and that electrical storm that's happening within the brain, may only last 30 seconds, may last an hour. But after that fact, over the next few hours to days, is when this process takes place. Okay, so you get something that looks like this. This is an animal study that was done using mice. This is ATP here on the Y, time on the X. And we have a sham group that did not receive an injury. And then we have multiple time points after injury in which ATP was measured. 1 minute, 10 minutes, 30 minutes. At 2 hours, we reach significant difference. 6 hours, they hit the peak low. 15 hours, still significant. 24, still significant. 48, still significant. And it's not until 120 hours, which is actually 5 days, that this ATP has gotten back up to normal. Now, this is an animal model. I'll show you the human study after this. But in this period, this is what we know, is that when you're significantly different in this reduced ATP state, your brain is actually in a more vulnerable state. So a lighter impact will set you off for another concussion. And that second concussion now could drop that ATP level very, very low and potentially actually permanently damage brain cells. Okay? So this is second impact. This is again looking at mice. And so we remember that the animal model was a 5-day full recovery. So they had a control group here, so no impact. They had a mild MTBI, so the middle group here had 1 mild traumatic brain injury. This group here on the very end had a severe traumatic brain injury. So you can see the differences in the ATP levels. Okay, so it's much more reduced in a severe brain injury than it is in a mild. Now they had 2 other groups. They wanted to see, okay, if we were to get a second impact throughout the recovery phase, how would that look? So they had one group, and they waited the full 5 days, that full recovery, or almost recovery, and they found that a second impact there made it not significantly different from just having 1 injury. So that means if you get a concussion, you fully recover, you get another concussion, it basically looks like another concussion. They're independent events. Now, they had another group that they gave a second concussion, at day 3 during the recovery. Now, that group was not significantly different from the severe traumatic brain injury group because their ATP reductions were so low, and actually 10% of the animals in each one of these groups actually died as a result of their injury. So, severe or 2 mild traumatic brain injuries are additive, provided they're within that recovery period. So the big thing that we want to promote is recovery. Making sure that people are fully recovered before we're letting them back into play. Okay? So this is a human study here, and we can't directly measure ATP in humans. However, there is a technology called magnetic spectroscopy, which can look at different metabolite levels within the brain. And the one that we're concerned with here is NAA, N-acetyl acetate. It has an unknown biological function. We don't really know what it does, but we know that it's produced by the same mechanisms that produce ATP. So if ATP is deficient, your body basically will shut down NAA production in order to try and make more ATP versus NAA. And as ATP stores come back on, NAA stores will rise as well. So the R-squared value here is about 0.8 for correlation between the two. So they're pretty well matched. So this is a human study here. This was done in Italy. This is the largest study that was done. They had 40 concussed subjects, all sports concussions, and they had 30 controls. And they put them through a 30-day process, and they measured them at day 3, day 15, day 22, and day 30. And so this is the control group here. And we see at day 3, there's a significant difference between the controls in terms of their NAA values. At day 15, there's a significant difference still. Day 22, still a significant difference, but these 2 stars represent that it is exponential, and there is a significant difference from day 22 to day 15 in terms of recovery. And now at day 30, finally, there's no significant difference between the controls. Now, if anybody is keeping up with concussion literature, a lot of the stuff up there says, well, it's a 7-day recovery. And I've heard a lot of people arbitrarily say, well, I went to emerge and they told me, take 2 weeks and that's it. Well, that doesn't really fit with the metabolic correlation. If you look at the animal studies and how it actually is a vulnerable time period, should you get hit again during that time period, we have to make sure that people are actually fully recovered. And just in terms of symptoms, as judging when somebody is recovered, because another time, other patients will come in and say, well, my doctor said I was good to go. And I said, okay, what did your doctor do? Did they check your systems? Did they do any kind of measurements? Well, they just asked me how I felt, and I said I felt fine, so they said I was good to go. Well, that doesn't really work. Every single person in this study was asymptomatic by day 8. Most were asymptomatic by the day 3 initial visit. This right here is a spin-off of the last study that I just showed. So this right here is a case series of 6 different athletes that decided they weren't going to wait the full 30 days to return. They were going to go back to their sport earlier. So after their first concussion, we have symptoms here. So we have headache, amnesia, nausea, amnesia. So here's the sports: boxing, rugby, soccer, kickboxing, and boxing. Here's the symptoms here. So 1 to 2, 3 symptoms for most of these people. The recovery or the symptom duration after the first injury: 3 days, 4 days, 8 days, 7 days, 8 days, and 5 days. Now, the time between injuries: 10 days, 9 days, 18 days, 16 days, 21 days, and 19 days. Now, here's their second injury. Much more symptoms in terms of number, but also the duration. This guy went from 3 days of duration after one injury to actually having 52 days of symptoms following a second injury during that vulnerable time period. 59 days, 44 days, 35, 24, and 33. Now, if we look at the NAA values, remember the return on one concussion was 30 days. Now, if we look here, after a second injury during that vulnerable time period, the vulnerable time period actually now increases: 120 days, 120 days, 90 days, 90 days, and 60 days. And so this is what we're talking about when we talk about chronic traumatic encephalopathy and these repeat injuries happening over time. There's a big media hype right now about concussion injuries in sports and how multiple concussions can add up to significant neurodegenerative conditions. However, things like this kind of let us know that perhaps it's not multiple concussions, but perhaps it's mismanagement of the concussions when they happen. People going back to play too early, getting hit again, creating a longer vulnerable period, and then exposing themselves to injury throughout that vulnerable period, and then potentially now it's longer and longer and longer and longer. And with each injury, getting hit in a vulnerable period, potentially adding to more of an effect there. So this is another study here that came out, and this is kind of getting with the chronic traumatic encephalopathy train. But they had groups of mice, and group 1 was given a concussion every month for 5 months. Group 2 was given 1 concussion every week. Group 2 was given 1 concussion every week for 5 weeks. Group 3 was given one concussion every day for 5 days, so all groups had 5 concussions. Sham went through the anesthetizing process, but didn't actually have an injury delivered. Then they tested them on the Morris-Water maze, which is a cognitive and memory task. And at 1 month after the final injury, groups 2 and 3, so every 5 weeks or every 5 days, were significantly different than the sham. Group 1, however, a concussion every month, showed no difference from the sham. Now, they left them alone, and a year later they brought them back in and retested them. Group 3, 1 concussion every day for 5 days, was still significantly different than the sham group. Whereas these two groups, group 1 and 2, where the injuries were more spaced out, had no significant difference from the sham group. So again, we're talking about recovery here. We want to make sure that people are fully recovered before they let them go back to play, because this might help to slow down some of those neurodegenerative processes that are starting to become linked with concussion injuries. So, first of all, we don't want to let people back because the ATP is low. There's also reductions in cerebral blood flow. Some of the animal studies have shown as much as 50% reduction in blood flow immediately following impact. So, any type of increased mental or physical activity can put strain on that system and have a hypoxic type of environment where the symptoms can come on after. And it also delays your recovery because your ATP is deficient, your energy is low. Burning energy, whether it's mental or physical, can delay your recovery. And it also takes much less force, as we've already mentioned, where the insult doesn't really match the outcome. So we look at Sidney Crosby, for example. He was hit during the Winter Classic. He was hit 4 days later, which was actually a pretty minor hit for the NHL. He stayed right against the end boards, and that one put him out for 320 days. So in my opinion, that was kind of a second impact scenario, and of course they're not going to come out and say that that was mishandled from the get-go, but that's just kind of my observation on it. There's also several neurologic dysfunctions. Now this isn't gross neurologic dysfunctions. Most of these people are going to have a normal cranial nerve screen, completely normal cerebellar testing, with no overt neurologic deficits. However, when you look at some of the subtleties like balance testing, processing speed, reaction time, things like that, they are delayed. However, they might still fit into the normative data, which makes this difficult, which is why we're trying to get people to get baseline testing before the sports season. So in our program, we have force plates, things like that, visual tracking and processing speed testing, reaction time testing, strength measures, motor strength, auditory and visual memory, neurocognitive testing through some of the computerized measures. But getting a baseline on some of these athletes allows us to pick up some of these really subtle differences and also help us to determine when they're ready to go back. Because when they come back into us, they'll say, yeah, I feel great, I feel fine. Okay, well, let's actually check your systems. Well, your balance is still impaired, you're not ready. Your reaction time is still slow, you're not ready. And so this gives us another check to be able to hold athletes back a little bit longer and make sure that we're not letting them go until we have the data to show us that they're actually ready to go. So the brain is vulnerable during recovery. We have reduced cellular ATP levels. And another insult not only causes a huge decline in ATP, but there's reactive oxygen species damage to the cell. There's significantly reduced cerebral blood flow, and there's a thing called second impact syndrome where a huge number of the neurons undergo apoptosis, and the individual can actually die as a result of this injury. Some of the two most famous ones, Rowan Stringer was a rugby player that died last year in Ottawa. I don't know if anyone's familiar with that story, but she'd had a concussion the week before, and she returned to play the next week feeling completely asymptomatic. Routine tackle on the field, hit her head, and actually died. Zachary Lysted was another guy who's a middle school football player in the U.S., and there's a law enacted in the U.S. right now in all 40 states that require not only the person to be assessed and pulled from the game on any suspicion of a concussion, but also they have to be cleared by a qualified medical health practitioner. And every state has different legislation as to who that qualified person should be. But this is a very famous law, Zachary Lysted law. So return to learn is a new concept that's coming out. This is a reintegration back into not only sport activity, but the learning part is back into cognitive activity. Now with people older than school age, you have a return to work kind of thing. And it's just an incremental increase in the amount of cognitive load that the person is sustaining. And so the first stage with any concussion, like we talked about the energy deficits, the blood flow deficits, complete rest is what you want. Okay, so you want the person not engaging in anything cognitive, not engaging in anything physical. They call it jail. You sit there, you do nothing, it's boring, it sucks. But that's what you should be doing because you want to boost those ATP stores. We also have a diet plan that we hand out, which is given to us by our naturopath who studies this and also chronic neurodegenerative conditions. Stage 2, light cognitive activity. So now you can try, okay, are you okay at rest? And each one of these stages is spaced apart by at least 24 hours, and they have to be asymptomatic within that 24-hour period before they can move on to the next stage. So, complete rest, they're like, okay, I feel fine. All right, try a little bit of reading. Pick up a book for half an hour, do half an hour of homework, see how you feel with that. If that causes symptoms again, well then they drop back a stage. Now they're resting for another 24-hour period, and they're going to try it again the next day. Okay? If they're okay with this, they can move on to the next step. They can go to half a day of school with restrictions. So we have letters that we give to the school that actually has different academic restrictions based on their symptoms. If they're having trouble with light sensitivity, we'll allow them to wear sunglasses in class, for instance. If they're having trouble with crowds and people and commotion, we'll allow them to leave class early to kind of get away from all of that. Different things like that. So we're just kind of catering their level of ability to the school environment. Stage 4 is a full day of school, again with restrictions. And some of these restrictions are no gym class. We don't want somebody playing dodgeball. No tests, no homework, just for the first little bit, just to allow them to kind of just sit in the environment and see how it goes. Stage 5 is light physical activity. Now this is when we get into the Zurich return to play protocol. So light physical activity is either a bike or the Buffalo treadmill test, which I'll kind of talk about a little bit. But it's a gradual increase in heart rate. So we put a heart rate monitor on, they come back into the clinic, and one of the problems with this return to play or the Zurich guidelines is that a lot of physicians don't have time to sit there and run a kid through a 20-minute treadmill test or a 15-minute treadmill test, whatever. So we have our staff, we have physiotherapists, chiros, ATs, all these different people that actually do this testing, so it's actually being done, which is different. But so light physical activity, get the heart rate up a little bit, see how they feel with that. If they're okay with that, they can return to sport-specific activities, but this is non-contact. So now they're allowed back on the ice, on the playing field, nothing where they could get hit in the head, okay? And then they see how they feel with that. Once you get the rotation, the environment of playing, that might set them off again. Well, now you go back to just doing light physical activity kind of on the sidelines. When your team's practicing, you're working out, just doing some light bike riding. If they're okay, then they go back on. Then they get into a little more intense drills. So this first step here is very light. This one is a little bit more complex drills, a little bit more team atmosphere, sport specific. Then when they come back, we have a test that was given to us by the Chicago Blackhawks medical staff. And it's a very intense physical exertion that also tests a lot of vestibular function. So this was given to me actually by their team physician. And he, in his opinion, he said it's the best test he's seen in the NHL. He's trying to get the rest of the league to adopt it. We've kind of taken it on. We've reduced it for some of the younger kids because it's pretty intense. But it's a high level of physical exertion. The heart rate goes up, the heart rate comes down, the heart rate goes up, the heart rate comes down to mimic a sporting environment. And then they're thrown into all sorts of different plyometric drills where they're doing vestibular stuff, they're doing burpees to try and see how their head responds. I had a professional MMA fighter in my clinic last night, and we ran her through the whole bike. So it wasn't, she could get up to full exertional heart rate. I think I had a heart rate of about 195. And then she started doing the burpees, and just doing that up and down triggered her vestibular response, and she started getting extremely dizzy, extremely nauseous. So that was it. I cut her down. And so I'm not going to let her go back into competition, obviously, because I don't think she's ready at that point. But this is another objective measure that we're using in order to determine recovery. If they pass, then we retest them all their baseline stuff. So if they pass that test, now we test your balance, now we test your reaction time, now we test your visual tracking, your neurocognitive function, all different things. And then if they're okay with that, then we allow them into full contact practice. If they have no return of symptoms with full contact practice, then we allow them to have full gameplay. Okay, so there's 10 stages here. The Zurich protocol has 6. We've added to it based on the metabolic literature showing that the recovery is actually much longer than 6 days. So adding these more steps actually puts them around day 22, day 25 by the time they actually get back to play for the most part. History of the injury, this should be your concussion examination. So you really want to know, were they hit in the head, were they hit in the body, did they lose consciousness? Even though there's no evidence to suggest that a loss of consciousness is a more severe injury. Some of the only things that suggest a potential longer-term outcome following injury are post-traumatic amnesia. And that's basically it. The rest of them, some studies have shown females tend to take a little bit longer, and also young children tend to take a little bit longer, and adolescents. But don't tell them that, because then we're dealing with a whole other problem. Mechanism, symptoms, immediate and delayed, what did you feel right away? If they have any symptoms following a hit to the head, that should be considered a concussion. Because it's just unsafe not to. Because if it is a concussion and there's that metabolic disturbance and they go back to play, this is when we would run into trouble, okay? But concussion symptoms are non-specific, and it's a difficult diagnosis to make. I generally go on the rule, okay, were you hitting the head? Yeah. What did you feel right after? Dizziness, headache, my ears are ringing. Okay, that's it. And I'll pull them out after that. That's what I just said. So your first exam should be basically just trying to rule out more sinister pathology. All right? Canadian C-spine rules. Everyone familiar with Canadian C-spine rules? Determining a need for an X-ray of the neck. Canadian CT head rule is determining in the emergency room who's going to get a CT scan. These are kind of the things I go through the checklist in my office, try and see, should this person go to the hospital and get a CT scan, or should they not? Should they do any of the X-ray of their neck? Then I do a cranial nerve screen, cerebellar testing, upper and lower limb neuro. I do a lot of visual tracking, stuff like that as well, to try and pick out any abnormalities. Generally though, like I said, I haven't had anybody fail any of the cranial nerve screens. I had one person that had some nystagmus on some age pattern stuff, and then I found out that she was actually blind in her left eye from birth. So that was the only finding that I've had so far, so most of these are going to be normal. So biomechanics of impact, this will just kind of let you have an idea of how much force is actually required to cause a concussion. So they have this head impact telemetry system. It's a bunch of accelerometers inside football helmets, and they follow them for hundreds of thousands of impacts throughout multiple seasons, and they try to see, okay, which of these impacts causes a concussion, and what acceleration do concussions have. So the range here, there's rotational and linear forces both applied. Some people will say that the linear force is more important. Some will say the rotational force that gets you. But I think it's a combination of both. They haven't really been able to narrow it down. The highest predictive occurrence found over hundreds of thousands of impacts was anything over 96.1 Gs. Now that's a lot of force. Your airbags in your car are set to deploy at 48 kilometers an hour. That translates into 60 Gs to your chest. So 96 Gs is a lot of force transmitted to the head. The range, however, is from 60 to 120. So there's a large range there. 5,500 rads per second squared. I don't have any rotational comparisons for you, but I'm assuming it's high. Okay, the whiplash study is looking at how much it takes to cause strain injury to the neck. Only 4.5 Gs it takes to cause mild cervical strain injury. Now, if you're taking 96 Gs to the head, there's a good chance you're taking at least 4.5 to the neck. So a lot of these patients have some underlying neck issues. However, they may not be at the forefront of their current complaint, so just keep in mind that there could be some issues there, which is where the physiotherapy and chiro end of it comes in, because we can treat those right away to kind of knock down any inflammatory reaction, make sure the range of motion stays up where it is. This study here was done in 1941 with cats, and they would stabilize the head and neck and deliver an impact, and if the head and neck were not allowed to move whatsoever, there was no concussion injury that occurred. If they removed that stabilization and allowed the head and neck to move just a little bit, now you've imparted an acceleration force. So the neck is very important in terms of these concussions. This study here, Viano, it was a finite element model looking at NFL impacts, and they found that the person that was about to do the hit would link up their body and their torso, and they would rarely get a concussion. The person getting hit was almost 90% of the time unaware that the impact was coming. And because of that, they didn't have any type of stabilization in their neck, and their head was allowed to move. When they broke down all the elements of the model and decided, and they tried to look at what would be more important for reducing head acceleration, the number one value that came out was stiffness of the neck. The stiffer you can make the neck, the tighter you can keep the head, and the less motion that occurs. This study here was looking at hockey players in Guelph, junior A hockey players, and they found that every single impact that happened had elements of both concussion and whiplash included in them, 100% of the patients. This is a 3-year study, I believe. So these injuries are happening, so make sure that you consider an underlying C-spine injury, and maybe refer them for some co-management to take care of that issue. This is a Canadian CT head rule. I'm not going to go into too much depth with this, but basically this is for mild head injuries, so between 13 and 15 GCS. If they're under 15 still at 2 hours in the ER, then that's one of the criteria. Suspected open or depressed skull fracture, any signs of basilar skull fracture, 2 or more episodes of vomiting. If you look at the New Orleans criteria from the States, any episode of vomiting is required, so it just depends on which guidelines that you'd like to use. Amnesia before the impact of more than 30 minutes, or a dangerous mechanism, and the dangerous mechanism is pedestrian struck by a motor vehicle, occupant ejected, fall from elevation of 3 or more feet, or 5 stairs. So the initial management from Zurich, absolute rest, we also talked about this. Physical and cognitive. So there was a study that was done looking at physicians' recommendations to patients following concussion, and a lot of them were starting to get on board with the physical rest, but not many of them were still not many of them were acknowledging that cognitive rest was also an important factor. So just for your information, cognitive rest is also very important for this. Proper nutrition is another thing. Like I said, we have a naturopath that's given us kind of a diet, an anti-inflammatory diet, and also a diet to help boost ATP production. So things like creatine, magnesium, things like that help promote ATP generation. So anything we can do to help that person recover those deficits faster, that's kind of what we're looking at. Proper education and reassurance. The ONF guidelines, Ontario Neurotrauma Foundation, just came out with their guidelines for persistent symptoms. The #1 way to prevent somebody from going on to have post-concussion syndrome, a long-term outcome, is early education and reassurance. Concussions get better. The whole metabolic process gets better, and you have to reassure your patients that they too will get better, especially now with the way the media is treating this. Patients will come in after years thinking they have permanent brain damage. However, all the physiologic mechanisms behind it aren't there to support it. The initial information that we have, we've had some referral pads at the back there for you guys if you have concussion patients that you'd like us to kind of co-manage with you. There's a stack of referral pads at the back. On the back side, on the flip side of those, we have initial instructions for the patient as to what they're supposed to do. So we've made it easy for you guys to fill out, just hand it to them on the back. They get in contact with one of our clinics. We have 15 right now in Canada, 15 different clinics running. 2 of them are here in Oakville. Return to learn, return to play, this is the stuff that we do. So this is stuff that's all done at our clinic and going through the whole process with people. We're also educating trainers and coaches to be able to kind of co-manage these with us, because part of this is sport-specific activity. They need specific drills to be able to run these kids through and kind of report back to us as to how these kids did. Medications. There's no evidence of any medications helping in the recovery process following concussions. Medications can mask the signs of a worsening condition, especially in the acute phases. You're looking for deterioration over time. Medications might be able to mask that, which isn't good. Players are not allowed to return while on any medication. So if you have a player that's taking some sort of analgesic for headache pain and they want to go back to play and you ask them how their headaches are, well, their headaches are great on the medication. They're still not allowed to go back and play because that medication is masking the fact that they still have underlying pathology. Potential to create rebound headaches. This is another problem. Somebody starts taking a lot of medication and all of a sudden they end up with symptoms months and months and months later. And it's because when they're not taking their medication, they need to take their medication and they end up with a rebound headache thing, which makes it difficult for us to try and determine is this concussion or is this medication related. Side effects may mimic concussion-like symptoms, so a lot of medications can cause dizziness and things like that. So just be aware of that. 80 to 90% of concussions will resolve symptomatically within 7 to 10 days. So it's symptomatically. This isn't meaning full recovery, okay? So that's one of the things that I really want to get across today was that just because you feel better doesn't mean that you are better. Numerous studies have shown that following symptom resolution, still deficits in balance, reaction time, and cognitive function. The metabolic stuff I showed you already kind of confirms that. Beyond a 22 to 30-day period, however, there's no physiologic explanation for post-concussion syndrome. So they have numerous theories on it. Post-concussion syndrome, there's 2 criteria. One is 4 weeks, this is the ICD-10, and one is at 3 months. That's when it becomes post-concussion syndrome. And they're basically the same criteria. There's several theories. One of them is a continued metabolic dysfunction. Perhaps it's a continued delay in the ATP coming back up to baseline. However, all the research has shown that at no more than 30 days, that has returned to normal levels. If they look at post-concussion syndrome patients, their ATP stores are normal. Continued axonal dysfunction. So this is some of the new research coming out looking at diffusion tensor imaging. Anyone heard of that? Yes? So, Carol's heard of it. Basically, diffusion tensor looks at water molecules diffusing down different axon tracts, and they've been able to pick up different neurons. You can actually see the function of the neuron inside the brain based on that water flow. Yeah.
How would, you gave an example of 6 subjects that had a second concussion and they had symptoms for 250 days. So are you saying that they don't have a biological reason for that?
They do. So sorry,
so you wouldn't be able to tell when someone's having their first concussion presenting to whether that is actually a second concussion, the first concussion.
Yeah, and that comes out in your history. So I mean, I had a patient come in a little while. She was a gymnast, and she was hit like 4 times in the past month. And so I treated her as if those impacts had been additive. So I kept her out a lot longer, just based on the history. But you can't just get a spectroscopy scan. There isn't even a machine in the GTA whatsoever. There's only one in Canada. It's in Montreal. So purely research-based tools. But I mean, yeah. So you don't really know, but that should come out in the history where you're asking. That's one of the questions I always ask: did you have another concussion recently, and how recently? And then you go from there. So this continued axon dysfunction, they have found deficits in people that have had a concussion anywhere from 1 to 6 months ago. Okay, so they do find these subtle changes within the brain, within the function of these axons. Now, when they look at people that have had post-concussion syndrome that are still experiencing symptoms, and then they compare those to people that are 6 months out with no symptoms, there's no difference between those two groups. So there could potentially be some underlying kind of incidental neurologic dysfunction still happening. However, that doesn't correlate with the symptoms, so we don't really think that's a symptom-generating thing. Psychological, this is massive, especially with the media like I was talking about, especially with misinformation from a lot of the healthcare practitioners they see. I've had patients go see neurologists and they tell them you're going to have permanent brain damage. That affects people big time, right? So when people come in to see you, there's all sorts of overlaying anxiety and depression that happen, especially if they're an athlete and they're told to do nothing. Sit there, do nothing, rest, you're not ready to do anything yet, and they're getting chronic daily headaches. Continued blood flow abnormalities, this is another thing that can linger on. Some of the SPECT studies in particular have shown this. However, the SPECT studies have also shown decreased cerebral blood flow with things like depression, low back pain, all these different things. So again, we're not talking about specific concussion-related findings. However, continued altered or decreased blood flow might be an issue. So the University of Buffalo has imparted exercise as post-concussion treatment. So in the acute phase, rest is best. We have an energy deficit, we want to improve on that. After 2 weeks, however, rest becomes detrimental because you have athletes or other people told they're not allowed to do anything. This can cause depression, anxiety, and all these different psychosocial aspects to the injury. And if they have an underlying blood flow abnormality, exercise can help improve that. So this is when we put them on the treadmill test. What we do is we try to figure out at what heart rate they get symptomatic. It's a very, very gradual increase in their heart rate on a treadmill test. If they start to say, yes, I'm starting to feel dizzy, I'm starting to get a headache, we say, okay, what's your heart rate right now? We write that number down. We take a percentage of that heart rate, because that's now their threshold for symptoms. We take a percentage of that heart rate, and we have them exercise on a daily basis at that reduced heart rate. So they're not reaching symptoms, but they're helping to get their heart rate up a little bit, start improving the blood flow mechanisms inside the brain, and then they come back in 2 weeks, and we retest them on that again. So this is it right here. It's the bulky treadmill test. The researchers that do this are John Letty and Barry Willer out of the University of Buffalo. If you want to look into it, they've done a number of studies. And they've just corroborated the findings with fMRI, actually, and improvements on fMRI following an exercise program in concussion patients. So they use this. We put them on 6 days a week for 2 weeks. Then we retest them, establish a new threshold, and then have them exercise at 80% of that. And we keep doing this until they're able to achieve full physical exertion. And oftentimes, somebody that's been told to sit there and do nothing, and if they had permanent brain damage, starts to feel a lot better. They're able to go to work now. They feel good. They can exercise. They can get outside. They feel more in control of their own destiny. And you're not doing any damage because the metabolic deficiencies are gone, and you're actually helping to improve the blood flow. If they're not exacerbated by the treadmill test, sometimes people will come in with chronic daily concussion symptoms. We put them on the treadmill, and they're able to they completely pass it. Some people even feel better. You know, I feel great. I haven't exercised in forever. I feel awesome. All right, but I'm still getting daily headaches. So then we have to try and figure out where those headaches are coming from. And this is when we kind of use our interprofessional network to be able to decide, is this a visual issue? Is this a cervicogenic issue? Is this a psychological issue? Do they need a neuropsych referral? Okay? So seek other explanations. I've been finding that a lot of these are cervicogenic in nature, and maybe it's my bias as a chiropractor, but I often find that I can reproduce a lot of these headaches just by palpation of some of the soft tissues of the cervical spine. Some of the referral patterns are directly into the head. The suboccipital muscles refer directly to the forehead, and also a band like around the side of the head. SCM goes right to the face, the whole face. Splenius capitis refers right to the top of the head. So they'll just say, I have this, it's like a knife stabbing right in the top of my head. And you start pushing on splenius capitis, and they'll say, oh, yeah, right there. So you treat that, and you get rid of that tightness or that trigger point. Then all of a sudden their headaches go away, and it's crazy. All right, and here's just some more evidence on that. So this is looking at whiplash and MTBI. Both are acceleration valve injuries, and as we've already mentioned, both happen together probably a lot of the time. We don't really consider it. But here's the symptoms of whiplash. Here's the symptoms of concussion. I mean, very much, very, very similar to that. Here's some other papers here. Trunk sway in patients with and without mild traumatic brain injury after whiplash. A similar pattern of balance impairments is present in patients with whiplash, with and without MTBI. Postural sway and cervical vertigo after whiplash. Postural stability using different neck positions in normal subjects and patients with neck trauma. This suggested neck problems, impaired postural control. So there's a lot of things here that might be considered as a concussion-like thing that could be caused by a number of other things, whether it's visual, vestibular, cervicogenic. There's more images here. Head and eye movement control with neck disorders. Crosby, if anyone remembers how Crosby's whole thing came to an end. Sidney Crosby's latest concussion-related layoff may not be a concussion after all, but rather a more treatable neck injury that went undiagnosed for weeks, if not months. After meeting with specialists on both the coast during the last week, he was told that he has a soft tissue injury causing swelling in the top two vertebrae. I believe it was an alar ligament thing, and they did some cortisone injections, and he's been back ever since. So here's our program, just to kind of give you guys an idea of what we're trying to do. First of all, we're doing these baseline tests to try and get all these athletes measured so that we kind of have an idea of where they stand so we can make a better determination of their recovery level. Education of the trainers and coaches, so we're providing them with a 90-minute course, which we're hoping that most associations will make mandatory for their trainers to have to take, talking about sideline assessments, just looking for the symptoms, knowing when to pull somebody back. And then we have a progression through our return to learn, return to play protocols, and then rehab for any of the ongoing symptoms and impairments. We have, like I said, we have vestibular specialists at Sheddon Physio. We just met with this performance optometrist who will be looking at some of the visual things and helping to retrain some of that. Cervicogenic issues, psychological, chronic pain physicians we have on board as well, and neuropsych. So we have this network built where we can kind of interprofessionally work together with these people. So here's how it works. So on your end, if you're looking for somebody to take over some of your concussion patients, or you have somebody that has long-standing issues, you can find any of our clinics online. There's referral pads at the back, like I said, and if you wanted to refer to one of our clinics, all of the practitioners have all been educated on all of this stuff, and they're all within our network, and they can refer. And if you put your fax number, they can fax you a report if you want to follow up back from your patient. So it's just kind of working together. We'll do all the hard work and work together on it. So, key points, significant impact and symptoms should be diagnosed as a concussion just because of the potential damage that can happen after. First visit should be focused on ruling out more sinister pathology, determining the need for neuroimaging. Education and reassurance is the best medicine initially. Rest is best in the initial stages. It becomes detrimental around 2 weeks. So if you're still symptomatic for 2 weeks, we got to start figuring out why and get on it. Because I don't want anybody sitting there for months and months and months. It's going to make them so much harder to try and get them back. Follow-up and return to play process should be monitored by somebody who knows what they're doing with it. Somebody with experience in it, and somebody that knows the literature and knows the evidence behind it. Symptoms are a poor indicator of recovery. So if somebody comes in and says they're feeling better, that doesn't necessarily mean they are where they should be. And there's no physiologic explanation for post-concussion syndromes. And there's many things that can be done for these people. However, not many practitioners know about it. And they just get told to do nothing, which is actually counterintuitive and counterproductive for them moving forward. So there's our website, Twitter handle, Facebook, all that good stuff. And like I said, there's some stuff at the back. Definitely feel free to take a referral pad, and we'll work together on this. Any questions?